Professor Karin Fox from the Texas Hospital for Women, working with our friend Mike Belfort, and she's the last speaker on intrapartum care. Karin.
Okay, and again, thank you very much. It is just a big honor to come to you from Houston, Texas in the United States, and I will be talking about the intrapartum management of the placenta accreta spectrum. For disclosures, I am partially funded to do ultrasound and MRI research in the placenta accreta spectrum from the NIH. I am also an unfunded investigator into the use of aortic balloon catheters. We are trying to build a big database, and I will freely admit in this discussion of management, I am mentioning a little bit about Jehovah's Witnesses. I am not a member of the Jehovah's Witness Church, but I do mention their website. And I will be discussing very briefly the use of some novel instruments for tamponade and occlusion. And again, I have to agree with Sally. It is nearly impossible to discuss all of clinical management in just 15 minutes, but I want to hit the highlights and discuss a pragmatic approach to the intrapartum management. Really think about how we can best match the chosen treatment modality to the clinical scenario and discuss some time-tested techniques. As my colleagues have really eloquently mentioned, hemorrhage is the leading preventable cause of maternal death worldwide, and we see this certainly rising with the incidence of the placenta accreta spectrum. And most of us consider that acute hemorrhage is probably one of the biggest risk factors when it comes to placenta accreta spectrum and the most immediate morbidity. Certainly we can have surgical injury to the urinary tract, and some long-term impact on fertility. One of the things that I think is most important, and it really begins with the accurate detection and diagnosis, is that when we have a patient who is referred to the appropriate center, accurate diagnosis helps us get the patient to the right place for imaging, for delivery, and then again, that time is precious. I tell my residents and students that time is blood and time is life. The ability to react quickly is essential. So how do we help improve that ability to respond? Well, certainly, as I mentioned, having the patient close by to our centers, especially when we live in a center like ours that is far away from many of our patients, having them move close by is very important. Another thing that we do is we really work on our unit readiness. That means having equipment available, whether it's medications, having a massive transfusion protocol that is not only very functional, but that is known to all staff members, from the surgeon to the bedside nurse, to the circulators, to the surgical technicians who help us in the operating or delivery rooms. And we want to make sure that, as I mentioned, we have equipment available. The slides that I am showing here on the left-hand side shows a cart that we have equipped with instruments, IV tubing, and things for hemorrhage. And on the top of it, we actually have a laminated photo of the massive transfusion protocol that I showed in the previous slide. That way, anyone can refer to it if they need quick reference. It has phone numbers, where people stand, things to remember in the heat of the moment. On the right hand of my slide, we also have what we call the accreta cart. This is a cart that is stocked with all of the equipment that may be necessary for a hysterectomy, and it is readily available in the operating room, where any staff member can go find equipment that might be needed, even in an emergency. If somebody says, I don't know exactly where to find it, we can say, please go inside that door and look on the accreta cart, and it's much more readily available. It's important to consider, while most of us do rely upon very good surgical technique and having the ability to have a blood bank, there are patients who we care for who refuse blood, or it's equally important to consider delivering in centers that may not have a robust availability of blood. What do you do? So it's important to consider contingency planning, to individualize the treatment plan to the individual patient. For example, I have taken care of some patients who very adamantly believe that they should not receive red blood cells or other components of blood, but will accept things like cryoprecipitate or other recombinant factors, for example, that don't carry as much of the potential to have a few blood cells in them. So every patient is individual. For patients who refuse blood, it's critical to discuss the additional risk early and consider alternative management techniques such as a cell saver or normovolemic hemodilution, whereby a little bit of blood is removed from the circulation but kept connected to the patient's vessel. The patient is given crystalloid back, and then as the surgery progresses, those units of blood that have been removed can be given back with her own blood. And again, I would encourage people to look to the www.jw.org website. As I mentioned, I am not a Jehovah's Witness, but I've found that this website has some very useful information for hemostatic and bloodless techniques for surgery if you must be encountered with them. I cannot express enough. I'm so glad to hear my friends and colleagues also discussing the importance of a team approach. We find this absolutely essential. When we work with our anesthesia, oncology, urology, radiology, and imaging colleagues, along with our nurses and other staff, we find that we learn from one another and we can absolutely improve the care we provide to our patients. In 2015, we published this algorithm of care that really truly begins with the identification in the antenatal period of PAS. And it goes all the way through to our operating rooms and our surgical management. But what I'd like to highlight here are the items that are highlighted in red. Over time, we have learned from one another, we have revised our protocols, and again, tried to individualize the care to the patient so that we're not admitting patients quite as early when not necessary, but clearly admitting them where it is. One thing that I would like to highlight, especially because we have folks joining us from all over the world, while our protocols are very helpful and they are a guideline, it is important to realize that what works in our center absolutely may not work in another. We have got a neonatologist at our center who can take care of babies as small as 23 to 24 weeks gestation. There are other hospitals, even within our region, that can only take care of babies that are 34 weeks and beyond. So to say that absolutely all babies must be delivered at 33 to 34 or 34 to 35 weeks because of the risk to the mother may not be appropriate. There are certainly other patients who very clearly can stay stable until 36 weeks or beyond. And it's the key is trying to identify those patients. So we really now work on trying to modify this. I'm going to spend most of my time on this slide. It is a little bit busy, but I'd like to highlight a few things. When it comes to the management strategies, there are three major approaches that Frederick, for example, and Eric have alluded to in their prior talks. One is conservative management, where the placenta is just left in place without being disturbed in part or in full after delivery of the neonate. And the goal here is to reduce surgical morbidity. It may be combined with adjunctive techniques such as the use of a balloon or embolization. But it's important to consider that while this has been shown very effective, especially if you look at the wonderful amount of data that's been produced from Loïc Santil out of France, they've shown very nicely that this may be effective in many cases. It's fertility sparing in many women, but there is a risk for recurrence of up to 22 to 28% of placenta accreta spectrum. And the median time to complete resolution, whether the placenta comes out, is expelled, or whether it resorbs, can be fairly long. It can be up to 6 to 9 months. So this is something that we must consider when counseling our patients. And in the large studies that have looked at this, there are still a substantial number of women who may require hysterectomy due to bleeding, DIC, infection, or discomfort later on. Now, Professor Santil and his colleagues from France have very nicely shown that even in the women who require a delayed hysterectomy, they tend to have a lower blood loss. But I think it's important to look at not only in the cases in which this treatment works, but in the cases where it may not work as well, or to look at some of the subtleties in the evidence. And this was also alluded to by both Sally and Eric in the discussion, that this disease process is not just a binary process, but truly a spectrum. And the group from France has recently published a paper that shows that the women in the group who went to immediate hysterectomy had a significantly higher proportion of women with placenta previa and placenta accreta spectrum than the people in the group who underwent conservative management. Pardon me. I'd like to turn also to the uterine sparing surgical techniques. This is the focal resection, or where a portion of the myometrium is resected along with the placenta that is invading, and then the myometrium is repaired. And the goal here is also to reduce surgical morbidity. The less surgery performed, potentially the fewer complications. And again, these procedures may use adjunctive techniques. These techniques have been published extensively by Jose Palacios Jarquemada from Argentina. He's got a wonderful series of nearly 300 patients in whom this has worked well, and Edward Chandraharan from the UK using the triple P procedure. So again, in some cases, adjunctive techniques such as balloon occlusion may be used. Again, what is important here in these case series is the caveats that are listed very briefly in these papers, where it is discussed that in cases where deep cervical invasion or lateral parametrial invasion occur, these are the areas that are very deep, as Professor Collins mentioned, or lateral where the blood supply comes into the uterus, these techniques may not work well. And therefore, there are a subset of patients who still may benefit from a complete cesarean hysterectomy. And finally, I'll turn to the cesarean hysterectomy, which of course is long been considered the definitive management. I don't want to say necessarily just the standard of care, but truly the debate between which type of management is best, so to speak, has been debated since the 1940s. But again, this may come with the use of temporary ureteral catheters, with or without an intentional cystotomy, opening the bladder in order to avoid bleeding from placenta very nearby. This mode of treatments clearly requires a very strong surgical set, especially once deep in the pelvis, and has a higher rate of urinary morbidity, whether or not that urinary opening was intentional. And part of what I'd like to discuss about these deep invasive placentas is the fact that when we think about the uterus and the placenta and the pelvis, the bony pelvis is like a large bowl, like a salad bowl, with a small soup bowl within it. So the pelvic outlet near the cervix and the parametria is the smallest bony portion of the pelvis. And when we have a big invasive placenta previa and accreta, especially if there's lateral involvement, you're working within the narrowest portion of the bony pelvis where most of the vasculature is involved, and it becomes a significantly more difficult dissection. So again, which one is best? I think we have a lot to learn, and these are the big questions. I think turning the attention away from which is best to which cases might be best for individual patients becomes very apparent. And I give the credit also to Professor Collins. She's mentioned this before. It may come all down to patient selection. So what goes into our decision making when deciding an approach? The anticipated severity and the location of the pathology is very clear, and this is why imaging is so important. What local and team resources are available at your center? For example, in France, they excel at doing conservative management. Here in Houston, we excel in doing surgical management. It may not be the same if I'm attempting conservative management in my center. And then again, taking in patient factors such as their desire for future fertility, whether or not they're coming in bleeding or having contractions, may dictate the therapy that is required. Now I'm going to shift a little bit to some of the basics that apply to whatever type of management technique that we're using, because again, this is clearly a morbid procedure and hemorrhage really becomes one of the biggest risks. And so one of my favorite tools is to use the thermostat in the OR. And why? To keep the patient warm, because we need to remember the lethal triad. Whenever we have significant bleeding, whether we're attempting conservative management, focal resection, or surgical hysterectomy, we have to consider that heavy bleeding can lead to coagulopathy. Why? Because of consumption and dilution of clotting factors. When a patient becomes cold on top of that bleeding, the patient then has vasoconstriction. They're not oxygenating the periphery as well, which leads to acidosis. Also, clotting factors tend to work less well when the patient is cold. For every 1 degree Celsius, it has been shown that the clotting factors work 10% less. Both of these factors then also accelerate abnormalities in electrolytes such as hyperkalemia and hypocalcemia, especially when a massive transfusion is ongoing. So it's very important that we care for the entire patient throughout this in order to prevent this kind of scenario where we just end up in fulminant DIC and massive hemorrhage. And I've seen this sadly, not only in cases where we have a surgical technique, but also after vaginal delivery when the amount of blood loss is not recognized. So how can we help ourselves when we're in the operating room or delivering? Of course, we here place our patients in lithotomy position using padded stirrups. Why we're better able to visualize bleeding coming from the vagina while we are in the cesarean or the hysterectomy. This can be a source of hidden bleeding that may go unrecognized unless we have a circulator looking every 15 minutes or so. We also ensure adequate lighting, whether it's with a headlamp or lights above. And the use of a self-retraining retractor is extraordinarily helpful. And I cannot emphasize the need for very clear team-based communication where any person in the room, whether it's the circulating nurse, the anesthesiologist, a medical student, is allowed to, not only allowed to, but encouraged to speak up if they see something that may be hazardous. It helps keep us from doing something that may cause the patient harm. I also like to consider that, again, using a bloodless technique spares bleeding from the beginning. So here is an example of where we're using electrocautery to open the abdomen in a bloodless way. We pinch up the myometrium and create an avascular space just using simple sutures, making sure that we are away from the fetus below our fingers. And then we can open the uterus here far from the placenta. We're here at the fundus. And once we have opened the myometrium a little bit, we can use clamps to help exposure. And you can either use a linear stapler cutter, or you can place 2 fingers within the myometrium and cut using scissors or cautery. By elevating the myometrium, you tamponade the big bloody sinuses there. But then by sealing the edges, whether using a stapler or clamps, you can create a bloodless field. And by using a technique like this, you spare up to or more than 500 cc's just from the delivery alone. As I've mentioned, you can use a series of clamps if you don't have access to the stapler and cutter. And you'll notice that there's still ample space to deliver the neonate in this case. After delivery, you can then replace the cord within the uterus. If you plan on using a conservative technique, of course, rather than using a clamp, you would tie off the cord. And then here you can just use a very quick whip stitch in order to close the myometrium. Some other ways that we can achieve hemostasis relatively quickly are to consider compression sutures. And these go by many different names and many different eponyms, but the goal here is to compress the uterus, whether it's front to back, top to bottom, or side to side, and reduce the perfusion pressure and bleeding. This can be used again with conservative measures or while trying to temporize, and also sometimes used with balloon tamponade. Sequential arterial ligation is also possible, both low and high along the uterine arteries, from the utero-ovarian artery, or sometimes even the IP ligament, and certainly from the vaginal branches. And some have used a uterine tourniquet, either a straight catheter or something like a large tie, in order to tie off below the placenta, but where the blood supply is coming in, and this can either be tied or held in place with a clamp. But I would caution, if you have a big bulging placenta like those shown earlier, not to push into that big tense placenta, because that can also cause bleeding. So the surgical approach when trying to dissect the bladder is very tenuous. So I recommend a very slow and meticulous approach, and attempting to control the blood supply from the uterine arteries before extensive dissection of the bladder. Now, others recommend dissecting very slowly and meticulously the bladder before attempting any uterine blood supply, and that would be especially in cases where a focal resection is attempted. It is possible to clamp the catheter and fill the bladder so that you can identify the bladder margins, and this actually helps you see much better to avoid an inadvertent injury. However, in some cases, we have performed a deliberate cystotomy to ensure that we can see exactly the margins of the placenta and bladder. If this is done, it's essential to do a 2-layer repair of the bladder and to leave a catheter draining the bladder in for a minimum of 7 to 10 days to allow appropriate healing. Now, again, our major goal, even once the uterus is out, is to stop the bleed, and pressure goes a long way. Some new devices that have been developed and used extensively in combat and also in trauma include specialized gauze packing that are impregnated with either chitin or kaolin, both of which help activate the coagulation cascade. So not only can you place a gauze inside the uterus, inside the pelvis, gently to hold pressure, but you can also help localized clotting. There are also some new cellulose matrices that have been developed that are also impregnated with powdered fibrin and thrombin, so that when applied, these patches do resorb into the system, but they also help provide a seal to help stem bleeding. And we have used it on some areas where there's a little rent in the placenta, hold gentle pressure to avoid creating a bigger tear, and it can work quite well. A variety of balloons have been described for use within the uterine cavity, but also within the pelvis after a hysterectomy should pelvic oozing require some tamponade. And again, these can be very helpful in temporizing. Now, when it comes to aortic occlusion, this is really one of those emergent techniques that we can use to slow down bleeding to the entire lower body. Now, this is an actual picture from an obstetrical textbook from 1922. I do not recommend this approach. We do have the ability to place a balloon within the aorta. I would recommend strongly, if you choose to use this type of system, that you have a vascular surgeon or an interventional radiologist who can assist, because it's very difficult to manage the surgery and the balloon at the same time. And any intervention into the vessel may also cause injury to that vessel. So it's really critical that we have additional support. This is something, again, being studied, and I'm interested not only in its effectiveness, but also the risks involved. If you have a good vascular surgeon or the skill set, you can also cross-clamp the aorta temporarily, and do not underestimate the benefit of just simply applying gentle manual pressure on the aorta from an assistant, but below the level of the renal arteries. And again, this is certainly not a permanent management, but something to temporize until surgical control of the surgical field can be obtained. Again, our ultimate goal is to have healthy mothers and families, and this absolutely starts with all of you who are helping us identify these patients and getting them to the appropriate centers. And again, I thank you so much for your time. It has been a gift and a pleasure. Thank you.
Wonderful, Karin. Thank you very much. I just want to ask you a couple of questions. The first one is the timing for you. You alluded to it, but when would you plan an elective cesarean section? When
That's an excellent question. I saw a lot of questions about this in the Q&A text boxes. We routinely plan our cesarean deliveries within the 34 to 36 weeks window. Now, there was the big decision analysis that was done that in the United States, looking at reporting 34 to 35 weeks as the optimal timing of delivery. I think a lot of us here, including the folks who wrote that paper, have acknowledged that it may be time to update that analysis, because again, it's been about 10 years since that was published. We acknowledge that there is a benefit when patients and babies are stable to getting the neonate to 36 weeks. There's less time in the NICU. Moms are more likely to go home with their babies, and that's very important to a lot of mothers. It is critical.
How predictable is it?
Exactly, it's a great question.
It would be nice to go to 40 weeks, but
yeah, exactly. Exactly. Well, and what we have found in our data is that about 40% of our women develop contractions or bleeding that push our hand to deliver a little bit early. And the average time at our center has been between 32 to 33 weeks in those women. But of course, we are getting the highest risk women at our center. So that being said, it does have to be very individualized. We schedule our surgeries between 34 to 36 weeks. If I've got a woman who has had a history of prior preterm birth, bleeding early in the pregnancy, or comes in with contractions, they are much more likely to go on to deliver early. Conversely, if I have a patient who has had no bleeding throughout pregnancy, even if it's a big invasive procreta, is very stable, is willing to come into the hospital and stay, or lives within 5 minutes, then I'm much more comfortable waiting until 36 weeks and trying to
Sally?
get her that far.
Sally, when do you plan your cesareans?
Well, the data that we're getting through from the ISPAS database actually backs up what we've seen in Oxford. If you have a really, really bad PAS at the absolute worst end of the spectrum, it's invaded right out through the uterus, it's into the pelvic sidewall, they're really solid. They don't tend to bleed and they don't tend to go into labour early. So the worse your PAS is, the less likely it is to force your hand early on. The small areas of accreta, the accreta previas, these are the ones that tend to bleed early and force your hand. When we analysed our data in Oxford, our average gestation at delivery was 35 weeks, and that was over 80 women. And of our emergency deliveries, we only had one that was done outside of Monday to Friday, 9 to 5. So we may have had women who we'd been planning on delivering at 36 weeks, but came in a bit early, but gave us time to deliver them during office hours and get the team together. But on average, we time it according to whether the woman's bleeding, whether she has a history of preterm labour, and how severe the PAS is. If she's not bleeding, she's never had a preterm baby, and she's got a FIGO grade 3 accreta, they tend to be delivered between 36 and 37 weeks, and we rarely have them come in early because these placentas are so bad, they don't move, they don't bleed, they're right the way out of the pelvis.
Mohammed?
Yes. Thank you, Karen. Two things about the timing of delivery. We, of course, like every other center, to deliver patients somewhere between 34 and 37 weeks. But trying to close the gap, we did a small random that will be published soon, comparing 35 to 36 weeks and 36 weeks to 37 weeks. And we found that many of our patients who were planned to be delivered at 36 to 37 weeks either went into labor or got some bleeding. So actually, we're not continuing the study. And most of our cases are planned for delivery between 35 weeks and 36 weeks. 34 weeks or less, of course, are reserved for patients who are symptomatizing. In our center, although it is a tertiary center, but babies delivered at 34 weeks definitely will perform less than those at 35 weeks. So my recommendation, unless the patient is bleeding or going into labor or having hematuria, because these patients who have a pericreta invading the bladder and bleeding into the bladder, those patients will bleed early. So these patients might be delivered a little bit early, maybe at 34 weeks. But generally, I would recommend 35 to 36 weeks.
Okay, and Karin, now on the issue of, you gave that very nice slide of the options for surgery. What is the percentage of hysterectomies that you do?
Oh, that's excellent. I would say that the percentage of hysterectomies is very high in our center. It's about 80% or more, but that's simply because that is the approach with which we have become very familiar and in which we have great confidence. However, there are some definite cases. For example, if we can see that there is just a focal area, not near the cervix, not on the lateral side walls where we can for example, place our hand around and there's healthy myometrium below, we will resect that out and repair the uterus.
So in a sense, your answer is our management is hysterectomy, except some cases.
Correct.
So when you're thinking,
yes,
you're going for hysterectomy. And
yes,
Mohammed,
well, and yes, and I think, but I think we're shifting a little bit to trying to identify those patients for whom it will be safe. And we also have the concern that many of our patients in the United States have government insurance that they lose after 6 weeks if they do not have private insurance. And so if they go back home to a rural community with a placenta still in situ and then have a complication, that becomes a big problem for them and their local providers.
And how, I mean, there's a lot of questions actually on that.
Yes.
How often do you get complications if you leave the placenta in for 9 months? How many cases would have with come back with sepsis or sudden nasty hemorrhages?
Yeah,
I mean, how safe is that process?
Exactly. And I think so far the studies have been highly variable. Again, in France, they have a very high success rate. We're only about, and correct me anyone if I'm wrong, about 20% of their patients require a hysterectomy ultimately. In other studies out of Scandinavia, they have been cited as high as up to 58% of cases. And we are looking at this data also from the ISPAS, and that should be coming out shortly. And
you, Mohammed? Safe hysterectomy and the rest is blah, blah, blah?
Yes, totally. Our policy is cesarean section and hysterectomy, unless, of course, the case is or can be managed by conservative surgical approach, not conservative therapy where we leave the placenta and ask the patient to go home. I don't recommend that. I know that in France they do it, in some other centers they do it, but these series, when they were tried to be repeated some other places in Europe, like in Belgium, for example, I think the complication rate was very high, and I think they have stopped doing that. So I don't recommend leaving the placenta in situ and asking the patient to go home. The only place for leaving the placenta in situ is when you are faced with a case of placenta accreta that you're not prepared for. Either the center or the surgeon, they are not ready to do that. So you can leave the placenta, you close the uterus, and take the patient to the center where they can manage properly by doing surgery, delayed surgery, 2 days, 3 days, 1 week later, but definitely not asking the patient to go home with the placenta inside.
So, okay, so we get rid of, I mean, at least this panel of the issue of conservative management.
No, I disagree. I totally disagree. We conservatively manage a lot of women.
Like what percent? Just give us a percent.
So what percent? I currently have a case series that we're hoping to publish, which is 11 women out of our 80 since I started auditing our service. So it's not a huge amount. The important thing about conservative management is patient selection. So antenatal hemorrhage equals postnatal hemorrhage. We all know that, basic labour ward rule. So never offer it or do it to a woman who's bled antenatally, because they will bleed postnatally and they will come back and need a hysterectomy. Don't offer it to a woman who only has a partial accreta, increta, percreta. It has to be the full placental bed. So we only offer it to women who have a very, very bad percreta, grade 3C, grade 3 A, B or C. And when you do it, you take the baby out through the fundus and you do nothing. What damages the women, what causes the problems with this is when we tinker. You do uterine artery embolization. Well, if you embolize and then you look at your uterus with ultrasound, you'll see that the placental flow has disappeared for a bit. Scan them the next day, all of the collaterals have kicked in. That placenta is as perfused as it was before, only now it's had an ischemic reperfusion injury. That causes necrosis, sepsis, infection. You know, if you are going to do this, pick a really bad one in a highly motivated woman. Do not do anything to her and just wait for that placenta to go. And we had
what do you mean highly motivated? For what?
It's a bit unpleasant, to be honest, because they bleed and bleed and they pass brown.
For 9 months.
Not necessarily 9 months. The fastest that we've had a 35-week placenta reabsorb was 4.5 months. And at 4.5 months, it was gone. And what tends to happen is kind of they bleed and they pass bits of tissue, and then one day they'll pass the cord, and they recognize the cord because they say, oh, Dr. Collins, it was this horrible stringy thing and it came out. And you know, they recognize that. And with that tends to come the last of the necrotic tissue. And after that, when you scan them, the uterus tends to be empty, but they have to be motivated enough to put up with several months of passing brown, horrible stuff. They have to be prepared to take their temperature twice a day. They have to be prepared to keep coming for follow-up. So you can't just say, off you go, bye-bye, never see you again.
And what do you tell them is the chance of a successful subsequent pregnancy? I mean, because that must be the main motivation, no?
No, some of my women want their tubes tied, but they just don't want a hysterectomy. So I think I've only had one woman, one of my 11 chose to do it for fertility preservation. And the data that's out there basically says if you have a successful conservative management and you choose to get pregnant, then 80% of women will become pregnant again. And of those, 1 in 5 will have another PAS. And that's what I counsel them.
It has been
if I may just...
Aris, you? Yeah.
Kipros, the reason to avoid the hysterectomy in this woman is not fertility preservation. If you look at the casts that people have done where they have injected the vessels, the collaterals, especially around the cervix going up to the uterine vessels, are enormously large. And taking out the cervix in women with a placenta accreta is associated with high levels of morbidity, urinary morbidity, etc. So especially in St. George's, where the triple P procedure has been employed, and recently published a series of 50 cases where the placenta is identified antenatally, fundal incision is made, the baby is delivered, and then the placenta with the myometrium is removed, and then the uterus reconstituted. And the reason for this is not to preserve the fertility, although some women have subsequently become pregnant. It is to reduce morbidity from this very complex hysterectomy that might otherwise be needed.
Karin, you have the last word.
May I interject really quickly? Yes, thank you. I think that's a very excellent point. And I actually wrote with some folks here that is really the primary goal of conservative management. However, it's important to understand that many women in different cultures still value their fertility. And so these techniques are being increasingly employed, not only requested by patients, but also by providers as a means to preserve fertility. So while the intention is to just avoid morbidity, the practicality is that more and more people are using it to that end. And I think we do need to be extremely cautious and be very clear when counseling our patients what the risks are, what the morbidity is, the risk of recurrence, and again, that it's, again, we still need to learn.